right. Good afternoon, everyone, or good evening. Welcome to Webinar Wednesday. Today's session is going to be about health information by the numbers, talking about healthcare informatics. We have some great panelists today to talk to you about everything that's going on right now, healthcare analytics, that kind of situation. And if we go to the next slide really quickly, they'll all introduce themselves to you individually, and you'll get a chance to know all of their background, their research, and the things that they're working on now. But just as a quick overview, so you can see who's talking to you and what they're talking about, we've got Dr. Lily West, Lynn Unruh, Andre Koval, Variraj Gurupur, or Raj, like we like to call him, and of course, Hannah Wynn, who's going to be your moderator today. I'm going to go ahead and get things started. I'll pass it off to Dr. Larry West, who's going to get you guys diving in.
Hi. So I assume that those of you who are attending are interested in careers in this field, or at least finding out more about it. So my background, I have a PhD in management information systems with a secondary, my minor at the doctoral level was economics, a particular style of it. And that's turned out to be very relevant to what's going on in a lot of healthcare. And so I want to talk a little bit about it. And kind of the big takeaway for you is why this is a field with a lot of demand. In essence, the demand for healthcare information systems, and therefore professionals in that field, has been sort of bottled up. It just wasn't worthwhile in a lot of ways for organizations to spend a lot of money on healthcare IT. They spent lots on the hotel aspects of healthcare, accounting systems, hospital census, billing, and such, but not on the healthcare aspects. Well, some things have changed that. So if you take a look at this slide, now this data is from 2017, but it's still, very relevant. So the U.S. spent $3.5 trillion on healthcare in 2017. And what that slide is the GDP of the top 11 economies in the world. The U.S. healthcare system would have been the 5th largest economy in the world if it was its own country. In terms of the size. Look at that. We're larger than India, larger than Britain and France and so forth. Well, so that's a lot. That's a lot of money. And whenever there's a lot of money being spent, people are interested. There's opportunities there. There's also problems. So if we could go to the next slide, please. So the US is not getting much bang for the buck relative to what it's spending on healthcare. Now, it doesn't mean that it's no good. We have an excellent healthcare system. The science is in good shape. The infrastructure is in good shape. But what each of these diamonds is representing, if you look at the vertical axis on the left, it's life expectancy at birth in years for different countries. And the horizontal axis is spending per capita on healthcare. Well, let's take a look at Japan. Japan has got way up at the top center of the slide. And any of the countries up there, they have a very high life expectancy at birth, which is a surrogate for just the health of the population. And they're spending $4,000 per person. Let's compare that to the US, way over here at the right. We've got about a 78.5 year life expectancy at birth, significantly lower than a lot of other countries. And look at how much we're spending. We're spending more than double what Japan is, more than double what, I don't know if that's Australia or Austria, but Canada, Belgium, whole slew of countries over there. We're just spending a lot and not getting the increase in health. Well, this has become a concern for anybody who's paying money for healthcare. This is governments at all levels who are spending on Medicare, Medicaid, employers who are seeing employee healthcare, health insurance costs become increasingly high, an increasingly high percentage of their business expenses. And so there's tremendous attention being paid to basically trying to bring those costs down, and also, by the way, improve the efficiency. And why this is relevant to you is that a huge number of these approaches center around information, data about healthcare, and so forth. Let's go to the next slide if we can. So we've seen a couple of, there's sort of two really, I have to remember to bring my hands up in front of the camera when I'm going to talk with them. There's sort of two big stroke ways that pressure has been applied to try to improve healthcare efficiency. The HITECH Act of 2009, which is actually a little subset, was folded in with the Recovery Act to try to get the economy boosted up, created financial incentives through Medicare reimbursement rates, both bonuses and then shifting to penalties, for organizations to adopt, for healthcare providers to adopt electronic health records. It's a long story, longer than you want to listen to today, but the economics made it unreasonable for most healthcare providers to spend money on these electronic health records. The government basically came in with its 900-pound gorilla of Medicare payments and said, we are going to reward you if you adopt and penalize you if you don't, if you're a Medicare provider. And that's a lot of them. That's a big chunk of the healthcare providers. Well, guess what? I'm sorry, let me skip to that second little bullet there. In addition to just encouraging the adoption of electronic health records, there's a tremendous amount of behind the scenes infrastructure being developed. So if you go to see a primary care doctor, they can do things like access your urologist records or your dermatologist records or whoever ologist you're seeing, and be able to integrate these organizations, the records. And there's all kinds of positive consequences of being able to do that. Well, guys, those things all demand healthcare professionals, people like that come out of programs like ours. The second thing that's going on, completely different, is the big payers, and this is large insurance companies, Medicare, Medicaid, are putting reimbursement pressures on providers. In the early days of healthcare and health insurance, folks were basically kind of fat, dumb, and happy, a lot of slack in the system. You went to see the doctor billed for whatever services they provided. Dr. Unruh has her cat stalking her.
Sorry,
and nobody cared too much because it wasn't horribly expensive. The money was there and they paid. But given the information I just showed you, something had to change. And one of them is that these big payers are basically using a my way or the highway approach to force providers to start changing their ways. And one of the things that they're doing is they're starting to pay for healthcare outcomes, not just for services they provide. Not only do you have to show that you did something for your patient, but there's a tremendous shift in requiring these providers to prove that they are effective in what they're doing. Go ahead and take us to the next slide, please. So one of there's a whole bunch of things, and this is my last slide. So there's a whole bunch of things that have now come out of this. So one, strong encouragement towards the adoption of the EHR. I already mentioned that. But the providers, because their reimbursement rates are going down, they're being forced to become more efficient. They have to lower their costs. They have to be more precise. Those of us who are old enough just realize we're not getting as much time with our doctors when we go to see them. There's a sense of rushing us through so they can get on to the next patient and the next bill they can send. But cost control, lowering costs and so forth are all coming out of these pressures. And then the other thing is having to demonstrate health outcomes, demonstrate to the payers that the providers are efficient. A kind of important consequence of this, or really addressing some of the first problems from the first two slides, we're seeing a shift towards population health. Now, what does that mean to us? One of the biggest things is all of this stuff requires investment in IT and people who are able to manage the IT, train providers to use the IT, implement the IT, and then more than anything, perform analytics. Is there room for improvement in the purchasing of tongue depressors or the patient management or the patient scheduling? All kinds of aspects that of the cost benefit payoff for delivering healthcare is under the microscope. And people that understand data, where it is, how to analyze it, are becoming essential in doing all that. And that's what our program trains people to do. A secondary consequence of this, I'm waving my finger in the air, I've got to get it up here, is this last item in here. We're seeing big structural changes in the healthcare field. The solo practitioner is probably going to be a vanishing breed. We're seeing large, multifaceted healthcare organizations because they can leverage the investments in a lot of things, but including the IT. By the way, this is very similar to the wave of mergers that we saw in banking at the last, starting in the 70s and carrying into the 80s and 90s. So that's it for me. The big takeaway is that there were several reasons why this stuff didn't happen before. And now it's happening, and we're seeing an industry that really was dormant in a lot of ways, really coming to life. And those are all opportunities for folks like you. And I'm done.
Thank you so much, Dr. West. Next, we have Dr. Unruh, who will be sharing some information with us about the U.S. COVID-19 health system response monitoring. Dr. Unruh.
Okay, good afternoon, everybody. I'm very happy to be here. Thank you for inviting me to be in on this webinar. I'm going to be talking about, I guess how this would apply to our students and people listening online and watching online, would be to show how when you're in this field, things can sort of just fall into your lap suddenly. So we've all been going through the COVID-19 pandemic since March is when the US sort of started deciding that there was a problem. And I was not at all prepared to receive an email one day from a team that I've been working on associated with the World Health Organization. And the email asked for, if you can go to the next slide. Email asked if we could join in responding to WHO appeal for help. It was the European Directorate of the World Health Organization that said, all these countries, this is towards the end of March, all these countries are starting to do things to respond to the pandemic. We have no way of tracking the response. Now, everyone's been tracking the disease progression itself, how many people are getting it, daily cases, mortalities, etc., but much harder to track all the various aspects of what countries are doing to deal with the pandemic. So at first I wasn't going to pay any attention to it, and then no one else on my US team was dealing with it. So I ended up taking it on and adding 2 new people to it, not my usual US team, and that was Andre Kobal, who's going to be talking after me, and Matt Alexander, who's at Virginia Commonwealth University. So we have a very good team that is now reporting. We got our first report in by the end of April. Actually, it was in mid-April, but about then was when we had some issues with our administration and the World Health Organization, which I'm going to talk about. But essentially what all these countries are doing, it's all the European countries, Canada and the US, and we're all sending in reports that get posted online that can be used in the future. And as I'm going to show at the end, they're starting to be used already to compare what different countries are doing to respond to the pandemic. So you can go on to the next slide. So these experiences with reporting over all these months, and I am committed to doing this until we have the vaccine and after, until we see that the whole thing is quieted down. So this is, I'm finding it's a tremendous commitment, and it's getting a bit better because we're just not making reports quite as often as we did at the beginning. But at the beginning, right in April, we started having issues because the US relationship with the WHO was becoming strained. And so when we went to submit our very first report, they looked it over with a fine-tooth comb, and there was a lot of things that they vetted and would not allow us to say because they didn't want to upset the Trump administration, to no avail, because by the time it was either around the time we made our first posting or right shortly thereafter, the Trump administration severed and said they were no longer going to be supporting the World Health Organization. So what the solution was, and still is, even though we seem to have severed those ties, our country, is that our report is posted on a North American observatory site along with Canada. So the US and Canada, and I believe some Latin American countries are also on there, or Mexico is on there. Sorry, it's North American. We're all reporting on the North American observatory site, which is linked to the World Health Organization site. So that was one thing with experiences in doing it. And the other was I spoke to the time-consuming nature. The other totally unexpected, and I'm sure everybody's gone through this over these months, is the kind of ongoing emotional turmoil, some, as Lady Obama said, some mild depression. But so every day I have to read the news and look at things that correspond to my part of the report, and that becomes rather difficult over time because you just like to be done with it. And I know people who have said, oh, I'm not even going to deal with this anymore. So, but I can't, and my teammates can't. So that's one. But the other thing, the thing that sort of mitigates those more negative and difficult emotions, are the feeling that we're doing something that is really historically important, that as far as we know, we're the only group in the US that is documenting our ongoing response, things the government's doing, what's happening with the PPEs, what's happening with testing, what's happening with hospitals, etc. So now we have some extensive quantitative data on the amount of hospitalizations, etc. But what is happening in terms of the hospital workforce, etc. So this gets into the more qualitative aspects of the COVID response. So we're documenting that and continuing. We're on our second update, our third report at this point. And next slide. So what were we required to do? What they asked us to do is to have a section on how the U.S. is preventing transmission, which is the very beginning part of it. How are we social distancing, wearing masks, et cetera, et cetera. And testing and all that. And then another part is, how are we ensuring that we're going to have a physical infrastructure? Do we have enough ICU beds? Do we have enough doctors and nurses, etc.? Third thing is, are we providing health services efficiently? Have we reorganized any of our services to focus them more on the COVID pandemic? Fourth thing is, how are we paying for them? And if you've been following the news, there's been a variety of ways of paying for service. The US government has passed several laws that have produced funding for hospitals, funding for people who don't have insurance. We're expanding some of our Medicare, some of our Medicaid. States are making Medicaid expansion. So how are we paying for the services that people need in this period? Although there's a lot of ongoing discussion about the need for some some more health reform in this country that to meet the needs of people who now have no jobs, and because they have no jobs, they have no health insurance. So it's an ongoing issue in the U.S. And the other thing is governance. How were we led? What was our leadership in, or what has been our leadership? What is our leadership in this crisis? And then there was another section on mobility. Did we enact border controls? Have we, you know, kept people from going to other countries? Do we keep other countries from coming in, etc.? Next slide. So we've had many findings, many things to talk about, especially since it's covered such a long period of time. Many things have changed over time. Initially, we were in a lockdown. Initially, the economy really went down in this period because everything was pretty much closed except for essential services. People needed to stay home except for essential things. Coming out of that, in the beginning of May, several states started coming out early, and most of those are southern states. And before I get to that, let me go back to the initial thing there about delayed stay-at-home mandate. One of the initial problems was that even though we did have a stay-at-home mandate, it came a little bit late, not hugely late. And we weren't the only country that sort of delayed in this, but just that little week or 2 weeks of not having that mandate meant that the cases were already rising. So it was harder to crush the rise and get that to go back down again. So there was a little delayed stay at home. But once we had it, and initially it was supposed to only be for a few days, we did have it until, like I say, the 1st of May for some states. There was low initial testing, very low. The federal government did not take the leadership on getting this testing spread to the places that needed to do the testing, setting up sites to do the testing, etc. Left it up to the states, and the states had difficulty doing this, and the states didn't get funding initially. Even though there was some emergency funding, it was not distributed immediately. And since then, now that we've sort of got testing up, testing capacity is getting there. We're getting to where we can meet most of the capacity in most areas, unless maybe Florida is still having problems, because we've had a real bad flare-up over the past few months. But what the big bottleneck now is getting the results back. We have a terrible time getting results back. I'm told that in a lot of areas it's 7 to 10 days. Now, I was just reading on the UCF website that the UCF testing organization that UCF has signed up with is getting our test results back in 48 hours, which is pretty good. The reason why we need quick results is that we need to do contact tracing afterwards, and it's useless to contact trace if you don't have your results back until 10 days later. By then, those people have gone out and infected a whole bunch of other people. So that is our current problem with stopping the spread. Another big problem is that many states reopened before meeting criteria, which would be a significant drop in the number of cases per day. They didn't have that, and they went ahead and opened up anyway. And the result of that is, and those states are specifically the ones that are having big problems now, including Florida. We see escalations in the number of cases up to greater than 15,000 per day in Florida, for example. That there's nothing that can be done about that. It's over and done. But once the reopening happened and things started escalating, a response could have been for states to back down. Some states have. Florida has not, with the exception of mandating backing down on some of the bar activity and otherwise. But we're still at a level where There's restaurant activity, et cetera, although with social distancing. Also, states could have mandated mask wearing in public, and many states have not. And even those that were having problems after they opened up have not. So that's just one of the things the U.S. is different in terms of comparing with other countries, where they seem to be much more accepting of wearing masks. As far as governance, well, our big issue here has been kind of a disregard for science, and I think that's a key takeaway for our audience is that science is really important when it comes to health, and we want to listen to the scientists and respect the scientists. And unfortunately, there's been way too much decision making on the basis of gut feeling from a lot of our top leadership, and a lot of leaving things up to state leaders, which would be governors. Some states have approached things more scientific than others, leading some states like Florida to not approach things as scientifically, and to therefore be in the lead for a surge of cases. And no unified governance. Things have not been unified from the top down. It's all what each state is doing pretty much, which in a way, given our top leadership, has been possibly the best solution we could do. But overall, in countries that have had more of a strong top-down leadership, I think there's been some, like for example, a nationwide mandate to wear masks in public. Politicizing of policies. This is not just in the US. I'm starting to see this in Germany now, but the issue of masks has been highly politicized, and we've had people that go out and protest wearing of masks who won't do it, won't wear them, etc. So that's been one of the key findings in the US and some other countries. Next slide. So that's been our response. So, and of course, I don't have data to do a correlation. So I'm not saying that this is exactly due to that, but there is a high correlation between our country's response, other countries' responses, such as India and Brazil, which have also been rather uncoordinated, haphazard. Brazil, for example, is particularly, their president particularly has poo-pooed the idea that it's even a problem, and you can see where Brazil is at. Versus the European Union, which went way up, got things under control, is starting to go back up again. And the funniest thing about this graph is China. China took the lead, came from China, and it got a grip on it, got the cases down, and it has not budged. So it's kind of amazing that they're way down at the bottom after having started the whole thing. Next slide. This just came out in the news. This is the other important that was the cases per day that you just saw. This is the total. We have 5 million cases greater than as of some unnamed day in August so far. But given testing limitations and asymptomatic cases, the actual number could be as much as 10 times higher. So it could be actually 50 million people. And in fact, today I just read where they're starting to think that there might be some community immunity building up, that it might actually, we poo-pooed this and said, no, it's not, we're going to have a lot of people in order to have those that have gotten it to make bring the numbers down. But I think in some areas it might actually be starting to occur. And then the really difficult thing to look at is the greater than 160,000 deaths. So we have had a lot of deaths. Anyway, I won't say any more about that. I got feelings about that. Next slide. So what is going to be done with all this? If you go to the COVID-19 Health Systems Response Monitor website, just type that in, you'll see that they have a country by country reports. Our report, you're forced to link to the North American Observatory, but they're also starting, they also have a page that links to a bunch of studies that have already been done, some of which use the data that we are collecting. And this one used the very data we're collecting, and it was about personal protective equipment. And so it compared countries, Italy, Spain, Denmark, France, Germany, and the Netherlands, and showed how these countries, you do sort of a qualitative analysis of categorizing their response. So they categorized Italy and Spain as not distinguishing between stocking PPE for ambulatory and hospital care, and the others is doing that. Italy and Spain were regional responses, and Denmark, France, Germany, and Netherlands were individual provider responses. So interestingly, the reports that I looked at, none of them had the US. I'm not sure if that's because we're such an outlier, or because we're just not in the European report, but we're in the North American report. So that's all that I have on my presentation. I hope that this gets you somewhat interested in a more qualitative side to doing informatic research in health care, and hope to see you in our classes or whatever walk of life you may be. Thank you very much.
Thank you so much, Dr. Unruh. Next, we have Dr. Andre Kovar, who will be continuing with the conversation that Dr. Unruh started about tracking the pandemic.
Hello, everyone. Welcome to this webinar. I'm excited to share a little bit about what I do and what I think about. So a little bit about myself. My background is in quantitative methods. I'm a psychologist by training, a PhD in psychology. A specific branch of psychology that deals with statistics and mathematics of testing and of understanding data about people. My subspecialty is longitudinal models, which deals with understanding how people behave, change over time, how things change over time. But my particular passion is in data visualization. I've learned early on in my career that when I bring up statistical models, even my most polite collaborators start to doze off and start rolling their eyes. But if I show them an interesting graph, the conversation continues, and we have lots of fun discussing it. So let me take this this presentation to share a little bit of the work that I do in terms of data visualization as relates to the project that Dr. Unruh invited me on. So in the next slide, you see a graph that after I was invited to the project, I decided, well, I want to understand a little bit more about how COVID-19 develops and evolves in each country. So you see an example of, so this is early response. So the horizontal axis is the days after the first case outside of China, and the graph and the line shows the total number of deaths, cumulative number of deaths. So if it goes higher, it means there's more deaths in that country. Each facet, each cell has its own scale, so we can sort of see the shape of this trajectory. So there's two interesting things to note. You see those dots? So there's each graph has two dots, one sort of greenish, another reddish. So the first dot, the green, shows the moment or the days when the first confirmed case was detected in that country. The second dot, the red one, shows when the first death was recorded in that country. So now it becomes a little bit easier to understand how each country was experiencing that pandemic. So you can see the United States at the very bottom right of the graph. So the countries are listed alphabetically. You can see that there was a long time after the first case was detected that the first death occurred. And also there was a long time after the first death that the epidemic really was starting to take off. And you can compare the shape of that curve, let's say from South Africa immediately above, or Norway also immediately above. You see that the United States is sort of the average of those two. So the shape of this curve, and also how rapidly this curve is taking upward after, let's say, the first or the second dot, can tell us something about the nature of this of how epidemic was evolving in that country. But so this is the final result. So the next slide tells you a little bit about the under the hood details of what's happening. So one of the greatest statistician of 20th century, John Tukey, once famously said that statistician is the best job ever because you get to play in everybody else's backyards. And this is certainly true. I get to, I'm getting the data from online sources. So in this case, it was the European Center for Disease Prevention and Control. I clean and analyze it with tools such as RStudio and GitHub. And you can see the link to my GitHub repository where these analyses are done. And then I ask questions such as you can see on the next slide. This is where the fun is, because I get to ask questions, then talk about those questions with experts. So one of the questions I had earlier on was, how did COVID-19 unfold in the world? Well, specifically, what if we what is the sequence of when the country gets the first confirmed case and it gets its first confirmed death? And how long was the duration between those two events in each country? So this graph tries to answer that question. So you can easily see two groups or two waves that the COVID was unfolding on. You can see the early group ending with Belgium that got first detected case early on. And there's this pause, which I still don't know how to explain. For about 2 weeks, no countries were reporting new cases, but then the second wave of the spread occurred. Next slide asks, what country had the heaviest early toll? So a slightly different way to represent the data, you can see that the total cumulative deaths at 100 days after the first confirmed death outside China is mapped onto both the size of the bubble and the position of the bubble on the wide scale. So you can see that the first 10 countries, starting with Belgium and ending with the United States, are sort of in the lead in terms of the total confirmed deaths, but the variability across those countries is really huge compared to all the countries that come after next. The next slide asks, so how can we measure the unfolding impact of COVID-19 within each country? So the top row talks about 5 different metrics we can think about. So the first 4 just gives you the number of cases. The second gives you the cases per million, so adjusting for population, the number of deaths, and also the number of deaths per million. So this is all that row is for the United States, right? And so how do we compare those? So which metric do we choose in order to make meaningful comparison across country, as you see at the bottom graph? So if we switch different metrics, would the trajectory tell us something else? The next slide shows how we can look at not how we were counting the impact of the pandemic in the country, but what the country was doing in response to that. So University of Oxford started this data set, which is available for free in public domain, called Government Response Tracker, which they measured they had a small army of volunteers who were recording how each country was taking, what steps they were doing with respect to economy, with respect to public policy, and so forth. So they compiled this, aggregated this response in so-called Stringency Index, which I highlight on this slide. So the higher the Stringency Index, which varies from 0 to 100, the more action a country is taking in response to this crisis. And once again, I've imposed the similar legend here. The first dot, the green dot, shows the first confirmed case in the country, and the second dot shows the first confirmed death in that country. So you can see how actions taken by the countries depend on those milestones. So next slide, when we combine all of those countries on the same slide, just to see what the shape it looks like, we can ask, how do we compare governmental response across countries? So you're already familiar with the notation. We've got the green dot, first case, red dot, first death. Now those vertical lines indicate the pandemic announced by WHO. I think it was March 11th. And then we have the 75-day mark from the first case outside of China and 100 days mark outside of China. And surprisingly, when you put every country on that relative time scale, this becomes quite telling. You can see how most of the first red dots occurred after the WHO announced the pandemic. So if we remove the dots, and the next slide will help us understand how we summarize the global trend of response. So we'll remove the dots so they don't distract us. And if we take the average of all the trajectories, and remember that each line here represents the stringency of response each country takes in response to this crisis, we can see, well, this is what global response looks like. When the pandemic was announced on March 11th, we can see a surge. But interestingly enough, you can see that this line started going up maybe like a week or 10 days before the pandemic was announced. So this tells me that, well, actually WHO could have been a little bit more proactive with it and not wait for a handful of countries to get really, really bad in order to announce it. But maybe if they announced it 2 weeks before, and we now know in retrospect that that decision was not taken lightly. There was pros and cons considered. Do we alarm people, or do we try to break this news in a less alarming way? But graphs like these help us understand what happened and help us tell these stories to people who can actually make decisions to either avoid a dangerous trajectory or to recuperate from this calamity in a better way. So that's my slides, and thanks for your time, and I'm looking forward to your questions.
Thank you so much, Dr. Kovar. Next, we have Dr. Gupar, who will be talking to us about some of the application in regards to this information.
All right. Thank you, Hannah and Katie, for having me here. First of all, I would like to announce that United States Patent Office officially approved our patent application that measures incompleteness of electronic health records. We have been working on this research for the last 5 years now, and we've got decent amount of success with a few journal articles and then funding from National Science Foundation and other things. So next slide, please. Okay, a little bit about myself and my academic training. I'm a little bit of an oddball, PhD in computer engineering. I was supposed to go and work for a software company, didn't happen that way. Ended up working for a hospital, for a large hospital in the state of Alabama, and like that ended up being in health informatics. I've been with UCF for the last 6 years, and I'm currently serving as an associate professor with the Department of Health Management and Informatics. Next slide. Okay, so what is my area of research? My area of research is to use innovations in computing and associated technology development to transform processes involved in healthcare delivery with the intention of improving healthcare outcomes. So this is a definition that I've been working on for a long time, and I asked myself, what is my contribution to health informatics? And broadly, this is how I contribute, and I'm a transdisciplinary researcher coming from the world of computer science and working for the world of healthcare. Next slide, please. So in a situation like this, we have given you a lot of information, and if you're already falling asleep, I just want to give you some, tell you some story that will wake you up, give you some information on the power of intelligent information systems and what it can do. There was one guy, a 50-plus-year-old person, regular shopper or customer with Target. He one day got a greeting card from Target stating that congratulations on your upcoming baby in your family. And the guy was like really mad. And what kind of joke is this? This is not a good joke. And he went to the manager and complained to the manager, this greeting card, this is not a good joke. What baby are you talking about? Then the manager apologized and said, this is computer generated. It was a mistake, stupid computer program. Please forgive us for that. You are a valued customer. Please keep coming. And 3 months later, the guy came back to Target, and he said, I'm sorry. You're right. It was my 16-year-old daughter who is pregnant, and it turns out that this information was caught by Target's billing information system, looking at the trends, the changes in trends in buying by that family. So this is the power of prediction, or the power of intelligent information system, how an information system can accurately predict what is going to happen, an event that is going to happen, or an event that is happening right now. So broadly, I also work in this area of intelligent information systems. Next slide, please. So as I said, I've been working in this project of data incompleteness in electronic health records. And we built an algorithm that would identify or measure data incompleteness. And then we are now working on different types of distributions that can accurately predict data incompleteness in electronic health records. This is a huge problem. Incomplete data can lead to different types of problems. Number one, we are a capitalistic economy. So the worst casualty of data incompleteness is problems with reimbursements for healthcare systems or healthcare providers. Some small healthcare providers in rural America have gone out of business or sold their facility to a bigger healthcare provider because they cannot deal with this problem. They just can't get enough things done in the right way to have a complete record sent to the payer so that they can get reimbursed. Now, what about large hospitals? Large hospitals are losing millions of dollars every year. And this is the information we got from our interviews conducted under the NSF ICOPS project. So this is a big issue from a reimbursement point of view. It is also an issue in terms of the patient not getting the right type of care at the right time. Like, for example, if they don't have all the data ready, the patient cannot be sent to the surgery room. And if the surgery is critical, and if there is a delay in surgery, you can imagine what can happen, right? So this project, I believe, is very important. and we've been working on. Next slide, please. We are also working on, continuation of this project in terms of chronic condition mapping package. We call it CCMP, chronic condition mapping package. So what we are trying to do is, we are trying to find out if a chronic condition that was identified in visit 1 somehow got missed in visit 2 and it resurfaced in visit 3. That shouldn't happen. Like, for example, I was working as a data manager for the Alzheimer's Disease Research Center. First visit, there is, moderate dementia and recorded. And next visit, there's no dementia recorded. And all of a sudden, 2 visits down the line, there's severe dementia or severe Alzheimer's recorded. So, somehow there was miscommunication. The chronic condition was not recorded properly. Alzheimer's is just one example, progressive disease like Alzheimer's. Another example could be something like heart problems, heart failures, and somebody's already got a heart attack, somebody suffering from cancer, all those type of things. Sometimes chronic conditions don't get recorded properly in a longitudinal manner. So this is another important algorithm we've been working on. I'm working with students from UCF College of Medicine, and these type of ideas come from their experience that they are working with the patients and all that. And they have some background in informatics, so they can take their experience and use that experience and apply and come up with an algorithm. So this is one thing that we are working on. Next slide, please. Okay, so I just wanted to keep my presentation short so that you have enough time to listen to our other great panelists. That's where I would end and let you present some questions and have our great panelists provide you the answers. So thank you very much.
Thank you so much, Dr. Gopar. Let's see here. Katie, are there questions coming in for our panelists?
Hey there, yeah, we did have a question come in. Larry answered just a little bit of it, but we do
Can't hear you, Katie.
Can you guys hear me?
Not too good.
I can hear you.
Yeah, I can hear you.
Okay, I'm going to turn my volume up. Maybe that's it.
Okay, no worries. I'll try to talk a little louder. So we
See,
do
that's
have,
better.
from one of our participants, Chuck asks, what are your thoughts regarding data integrity and the variances from each country? And this is in reference to you, Lynn, and Andre.
I can't hear. That sounds like it's a question for Andre.
So I think Dr. West already addressed it a little bit, but yeah, the data quality varies from country to country. Sometimes it's technical reasons, so some countries may not have the infrastructure to collect the data correctly. Other countries, like you can think of North Korea or Russia or Belarus, for example, have political motivation. So they don't want to report the accurate numbers because that is going to undermine their autocratic leadership, because that would create the optics of, the leaders don't really know what they're doing. So there's a variety of reasons not to trust data that comes in. And from what I know, it's been a major frustration among the researchers because they would like to treat each data, like, for instance, reported cases, as if the accuracy is the same across the country, but it's not. And most disturbing, we don't know which one or the degree of this inaccuracy. So that's in terms of data integrity. In terms of variability across the country, perhaps I'm thinking as a statistician, but variability is good. When something does not vary, that's when you have a hard time explaining things. When things vary from person to person, from country to country, it's good because you can relate that variability to some other measure, and that helps explain why things are different. So that's my response to that.
One of the things also I mentioned early in my talk about the electronic health records and the infrastructure behind them. The U.S., as developed as we are and as advanced as we are, has actually been slow to the table in having a national infrastructure for routine conditions reporting. And some of the motivation behind the HITECH Act and the electronic health records and the collaborative infrastructure, in addition to better patient care, has been to create the ability to do large population analysis on treatment efficiencies and so forth. But without that, now we have stovepipe reporting systems. So, we were late to the game. So just even and then you think about a lesser developed country. I see, by the way, that Mr. Wood is our only audience member. He's unmuted. So he may as well just, if he's got other questions.
How do you see the audience? Oops.
I thought I'd turn my
Oh,
camera
there.
on.
Hi.
I'm not dressed up very well today, so.
Well,
No worries.
I'm wearing shorts below my shirt and tie. So
I'm not wearing anything.
that falls under the too much information category.
Yeah.
Okay,
No,
I think
thank you for the answers. It was very interesting, and I was connected a lot with the College of Medicine at one point, and actually attended UCF a number of years ago and took a lot of stat and financial accounting things there. But I saw
In the College of Medicine?
No, I was back there during the transition from FT to UCF. So
Oh,
You're dating yourself.
interesting.
back when accounting went from 4 to 5, but I was with Siemens Healthcare for a long time and worked with Dr. German quite a bit.
Oh.
We did some hosting for some things when the college was first announced, and had a nice connection, and like to try to be connected to UCF and see how I can help support the college and the university and all the great work that happens there. And I'm now with a group called Health Catalyst. I don't know if you've heard of them or not, but we are a data analytics organization. I would call us an improvement organization that's driven by data. So anyway, I've enjoyed, I was on one earlier today, and I'll look forward to participating. If there's anything I can do to help with your organization, please let me know.
Okay, well, thank you.
And gotta say go Knights, and I want to hear a go Knights.
Hey, I'm an Aggie.
Charge
Go
on.
Go Blazers.
Anyway, but thank you for answering my questions, and I'll lurk at future webinars.
Oh, good.
All right, take care.
Come in.
Okay, so I'm gonna just take it over, spend the last maybe 30 seconds. I know that there might be some participants that are watching us on our live, our YouTube live, but I just wanted to make a quick plug that if anybody is actually interested in perhaps getting some formal education around healthcare informatics, if this subject is interesting to you and you want to learn more, UCF and our Department of Health Management Informatics does offer a master's in healthcare informatics. It's 100% completely online. It's convenient and flexible. You can complete the program in 2 years. There's no GRE that's required. We actually will cover a lot of the foundational information, so you do not need to have any experience prior, healthcare experience prior to applying to the program. And we do offer training, additional certifications, as well as the educational courses that are like Excel, Access, SQL, things that we can train you on so that you can apply that to your job once you graduate from our program. We also offer conferences and networking opportunities within this program. And something that's very exciting is that according to the U.S. Bureau of Labor Statistics, the healthcare informatics arena is projected to have an 11% growth in the coming years. And this number was actually captured before the pandemic, so I can only imagine that this demand is actually going to be increasing as we navigate these uncharted waters. So I think that is all that I have. I would like to thank everybody for participating in our webinar. Here's our contact information if you would like to reach out, have any additional questions. And again, thank you so much for attending our webinar Wednesday. And here is a list of the upcoming webinars and their dates. Thank you so much, everyone. And thank you so much to our panelists. Great job.
Thank you,
All right,
Angela.
thank you.
Thank you.
See you
Bye-bye.
next time.
Bye-bye.
Bye.
Bye.